Good evening. I have the distinct pleasure to welcome you to Nefesh, the opening session of Nefesh 2019. I have the pleasure of introducing our speaker tonight. I am Shalom Feinberg. Tonight's speaker is Dr. Klafter. Though I suspect he really doesn't need much of an introduction to here at Nefesh, as he's been speaking here and is a mainstay of speaking here now for the last number of years. His lectures and discussions are always insightful and provocative, and we expect no less tonight. Dr. Klafter has a rather impressive academic and professional resume, but at least from a Nefesh perspective, I would like to acknowledge something else. I'm one of the founding fathers, and what I've seen is that Dr. Klafter has put in hundreds and hundreds, and I'm not exaggerating in any way, of hours to help grow the organization. And for that, Nefesh and I are really very, very much appreciative. In terms of basic housekeeping, if you need your CEs or CEUs, go get them. CMEs as well, for that matter. And before calling on Dr. Klafter to speak, I thought an appropriate way to start his discussion tonight is the following. All right. Without further introduction, Dr. Klafter's talk is entitled Mission Impossible. With Dr. Klafter presenting your complex cases. Dr. Klafter.
Thank you. I always wanted a theme song, so.
Especially that one.
Yeah, absolutely. Okay, so the format is I'd like to have people present vignettes, and then I will respond and then ask others to chime in, and I will take responsibility to move the discussion on to make sure that we don't get too bogged down. But the way I'm going to organize this for my own thinking is that I think that when we're stuck on cases, and all of us get stuck on cases, anyone that doesn't get stuck on cases, I don't think is thinking or trying very hard in their work, is that I think there is a problem in one of the following three areas. The first area would be diagnosis and formulation. And diagnosis doesn't have to be like a DSM diagnosis, but it could be. And by formulation, I'll explain what I mean by formulation. The next area is that people have trouble with boundaries. I'm not saying that the therapist has boundary problems. It's usually a patient with boundary problems. There are some therapists with boundary problems, but that's a separate issue. But therapists that have good boundaries, they have patients with boundary problems, and they are so wrapped up in such kind of crazy interactions that they don't realize what they're being drawn into, and they need... That's really when I think consultation with an outside perspective is very helpful. I know that's what helps me when I'm in situations like that. And then the third area is technique. Usually one of those three areas is what helps rescue someone from an impossible scenario. And so I'll, in my own mind, go through all of those with you and just sort of thinking out loud as we go through. And hopefully, and then you guys will chime in with your thoughts as well. And hopefully we'll see if that's a helpful approach to think through difficult scenarios. But I think that you have to do it usually with an outsider. It's not a matter of experience and knowledge. I mean, that's also helpful to find someone with lots of experience and knowledge. But it's just someone who's outside the craziness. It's just very helpful to have an outsider and a set of outside eyes. And so a peer, a formal supervisor, a formal consultant. And so that's what we'll keep in mind as we go through. I'll try this to be like a mini consultation on each of these cases. So does anyone have a case in mind to start with? Okay, in the back row, you won. Your hand went up first. You're next, though, in the front row. Okay, so I'll summarize for the recording the case. It's a young man who lives in the Orthodox world and interacts with men all the time, unmarried, and feels lots of sexual and romantic longing for other men, apparently not for women, was at the age where he's expected to be dating to get married, was unsure that he could really go through with a marriage because he's attracted to men and not to women. And you felt that the work was doing well for a couple months, and you consulted with someone who has a reputation for expertise in working with people who have the term unwanted same-sex attractions. And then he dropped out of treatment, has since moved away, you've heard, and you're worried about him, and you wonder why the therapy didn't continue. So some general things about this. I think, we haven't heard the case in detail, so we can't really comment on what happened in the work and why he dropped out of treatment. And you had a consultant, so you were doing what you felt you could do. In the first case, I think it's worth talking a little bit on treating people who are gay and live in a religious community that it's not really possible to participate normally in communal life while gay, and whether these treatments are really, what happens to these treatments and what it's like to try to offer such treatment. And then what in general we do how do we reconcile ourselves with people who have dropped out of treatment and we feel that we were helping and we don't understand why they dropped out of treatment. So a couple thoughts about both. Over time, I've had a few cases of people who come in reporting very strongly a sexual orientation that is impervious to any change whatsoever, and actually the sexual orientation changes in treatment. They're not coming to treatment for work with their sexual orientation. They're coming to treatment for depression, for anxiety, for other problems. And just an example, a young woman, really brilliant woman who was in a graduate program in a science field, and she was coming in just for depression, for anxiety. She had been subject to a lot of abuse by her mother and was just working on those issues. She considered herself to be non-binary and queer, and was really only, she said, attracted to women. I would say that, and she wanted to make sure, she was concerned that I'm an Orthodox Jew, wanted to make sure she could work with me. So by the end of treatment, she no longer considered herself non-binary, no longer considered herself, I think she still called herself queer, but she was in relationships with men, and her orientation changed, but she was not seeking a change in her orientation. Her orientation was a compromise formation that she had developed for a number of reasons, and as she worked on the emotional issues with her mother, that just was no longer how she had to sort of manage her life. But people who come in reporting to be gay and wish they were not gay, I'm increasingly skeptical about the results of these cases. I was not too long ago consulted by a rabbi about a professional man who was caught having sex with teenage boys in a mikveh, actually, and he had been to see people who are supposedly experts in reparative therapy, and people claim to change, and we don't have outcome measures. We have really no idea if these patients change their orientations. So I'm increasingly skeptical, and I think there are some people who do change their orientations, but they're usually not coming to treatment for an orientation change. That's not the presenting symptom. And so I'm just not really all that optimistic. I think that people can be helped to manage what feels like a hopeless or impossible scenario in some way. Maybe that's what you're doing with him. But we don't really know. We don't know at what point, if he came hoping to change and wanting to be able to marry women and conclude that he just can't, or if it just became too painful for him to recognize this, that might have been why he dropped out. But, we don't always know why people drop out of therapy. We don't always know why that's the case. I think usually it would be good if we could hear about more cases where treatment fails, actually. there's now a series that two of my colleagues do at the American Psychoanalytic Association's annual meeting every winter, and they discuss failed cases. And they won't let you present a successful case that has like a happy ending. They won't let you do that. So I think that would be more helpful. There are cases that, people drop out and we don't know exactly why. I think that usually there is something, my experience with my cases where people have dropped out, I think that I usually misunderstood where the patient was and thought the patient and I were aligned with the same goals or aligned with the same frame of treatment. And I found out that actually, no, that was like my thought and not the patient's thought. It might be that these patients have trouble expressing, like, no, I disagree, you've got it wrong, like they're not good at explaining that. But usually that's been my experience, is that I am thinking that we're really working well together, and it's really my agenda leading the situation, and I'm unaware. I don't know if that happened with him, but it wouldn't be hard to imagine that would happen with someone with his presenting problems. Anyone else have any thoughts about this? Yes. Suggest to whom? Well, I guess if someone is in a lot of psychic pain and therapy helps them live with what feels like a totally impossible or irreconcilable dilemma, I would suggest just continuing to listen, continuing to work. Whatever the work is that's keeping the person there is helping in some way. So I would probably suggest, kind of a patient-centered treatment. I mean, I just don't think that what the person is getting out of it, it's very theoretical, the question you're asking, like, why is the person there? What are they getting out of it? What do they find to be a benefit for the treatment? Have they developed, look, all of us, I think, have friends in the Orthodox world who are gay or who we suspect are gay, and they work it out in different ways. I think that if you could work with someone and prevent them from getting married and living a duplicitous life with lots of affairs on the side and live like a life of more integrity, that would be like a great outcome. I know people who are gay and Orthodox, and they wish they were not gay, but they don't try to get married, and I don't know exactly what they do in all of their spare time and what they do, sexually in their lives. But they seem to have friends and happy lives and participate in Orthodox life and share with people that they trust and not share with people they don't trust. I mean, I think there are people that are able to work things out. So I think that requires a lot of therapy. I mean, there's just such a huge expectation to get married and have like a traditional family. And there are so many religious leaders that, think marrying someone off is like the outcome. Like, that's the good outcome. We got this person married off. That's really where a lot of the trouble starts, as we all know. So I think that someone like that probably needs lots of treatment for decades, or a decade or so. So I guess that's sort of my attitude. It's just like so much to try to juggle, and just such a terrible life disappointment. Like, it's just not the way Orthodox Jews are raised to imagine their lives turning out. So that's just a huge amount to struggle with. Some people leave Orthodoxy, some people stay in Orthodoxy. I think more and more people leave Orthodoxy over this issue as homosexuality is more and more accepted in the general community. And I think it's a challenge to us to make some sort of life possible in our communities where people don't feel they have to leave to live more integrated lives. So I would encourage someone to just keep working with that person. That's how I'd think about it. Well, okay, so the comment is, in other words, therapy doesn't help. No, therapy really, really helps, is what I'm saying. I'm skeptical that lots of people can really come and report that they are gay and that therapy will change their orientation. People that claim, I'm gay and I want you to sort of ungay me in some way. I'm more and more skeptical of these cases. I've met people who have been to people who claim expertise in reparative therapy or there are all new terms for this now, and I don't trust the results. I don't know why anyone trusts the results. It's all based on self-report, but I think the therapy can be very helpful. This is still a person who's going to have a long life, God willing, and if their sexual orientation is not, seems to be pretty firmly developed and established, then I think that they need a lot of help working out how life is going to work. But I don't think it's a question of can we make this person heterosexual or can't we? I mean, that's an interesting research question, but I don't think that's the question for therapists usually. That to me is more of a question for rabbis, actually. But for the therapist, whether or not the person's orientation changes, the person is going to need a lot of help, and I think therapy really, really does help. Thank you. Okay, so I think we'll move on to the next case. There was someone who beat you in front. I don't know your name. Sherry has a case. The wife wants out of the marriage. The husband doesn't want to end the marriage.
Well, they both agree. The counsel both agree that they think it's best if they can make the marriage work for the children and because they would like to have a family. But she's keeping less and less philosophy, and she keeps bringing up questions for him to go ask for them about whether they could do their kind of moving things around with visa, moving things around about all kinds of different kinds of law. She's not covering her hair anymore. She's starting to wonder if she's a scholar before the one she's putting in another one for Korea, and it's like she keeps raising the bar. So it's like, one of the things that I said to her is we have to be in the relationship if you want to work on the relationship. You can't be looking out there and what to do.
What do you mean by looking out there?
Well, she's looking at how everything is better out there because if she could live, she would be happy if she could be engaging in intimacy at any time and not be bound by laws. So he very much wants to maintain the relationship unit, but he's also like, he's not interested in her right now. They're sleeping in separate, one's upstairs, one's downstairs. And so I've been trying to conduct up a gathering information stage to try to understand where they're coming from and where they want to go. But to me,
So you've given us a lot. I think you've given us a lot of good details. Is there anything else critical to the question, or you've covered a lot of the details? Okay. So a few of the things you said. So this wouldn't be hard to summarize for the recording, but I'll just summarize it because you'll hear how I'm thinking about it. So this is a couple who are in their 30s, and the marriage is really seeming to fall apart. There's a lot of religious conflict. The wife is becoming less and less observant and seems to be unhappy with religious life. And the husband seems to be more interested in keeping the marriage together, perhaps, than the wife is. And also you gave some details, like you said, that she seems to be looking at how much life could be nicer or easier or more comfortable or more fulfilling if only she weren't observant. And you feel like, that's an attitude that's going to make it impossible to work on their relationship in some way. And you also mentioned that either they have no boundaries, you said, like they wanted to cancel an appointment at the last minute, and he tried to come over to your house to tell you, like, just not really right, and not acting like within normal professional parameters for you. So so a few thoughts about this. I think the first thing, in terms of like the diagnosis and the formulation, I do think that, and I'm curious if everyone here agrees or not, I do believe that there are couples where there's a major difference in religious ideology and they can live happily in their marriages. I've seen couples where one person becomes totally unobservant or one person becomes totally observant, and they love each other and respect each other's choices, and they can have happy marriages and relationships. And the marriage is more of a value to them than... Now, I've seen other things. I've seen situations where people end their marriages over religious differences. And I really, all the cases I've seen of that, I really believe that there was a deeply troubled or flawed relationship in the first place, or in certain, just a very superficial relationship with not a lot of real closeness or intimacy, kind of like a very traditional partnership to run a business venture at home. And then if the business venture doesn't run, it's like, well, what do I need this for? I'll go on and find someone who works better, but not the kind of marriage that most people would be happy in. So I think that my first, in terms of formulating the case, I would try to see the religious differences as a symptom or like a battleground for what's probably a power struggle in the relationship, is what I suspect. That there's some like, she's, you're burdening me with religious life, and I really want to be freer than this. That's what her attitude seems to be. And I think that the couples therapist has to see that for what it is emotionally. And I think when you're also religious, when you're observant, it's hard to do. I mean, we have a lot of our own religious commitments and beliefs tied up in that, so it's hard to get out of that. Now, when you said to her, you can't be looking out there, you've got to be really in the relationship. But no, I mean, that's where she is. Like, that's the case. She is looking out there. So to say, like, you can't be looking out there, you've got to be in the relationship, but then you're not really... I think you're asking her to sort of stop having this problem so you can work on the marriage. I mean, like, she really is looking out there. She really is. Now, whether that will continue to be the case, if the power, what I suspect are going to be power dynamics in the relationship, can be brought out, there might be less of a struggle about religious issues, or there might just be sort of a, some way of working things out between the two of them, that one person accepts, the other has a less religious life. I don't know. You said that he's very passive aggressive in a lot of ways, and so, if that's happening in the marriage, that really may be what it's about. But I feel like the religious issues are probably a very, very noisy distraction from power dynamics. And in terms of the boundaries, I think that one way I heard a teacher say this is that, therapy is a sport of two, or when it's couples therapy, it's a sport of three. It's a three-person game in couples therapy, but there's only one referee. When it's individual therapy, it's a sport for two, but there's one referee. The patient has the patient doesn't have to observe boundaries. Like, they don't come in, like there's no requirements for them to observe boundaries other than what you bring to the treatment. So the fact that people act this way is, it feels invasive when patients come to our homes, but it's very common, especially in the Orthodox world. It is very, very common that patients track down their therapists. I mean, they know people that know their therapists. They know people who are related to their therapists. They know where their therapists live. They know where their therapists go to school. They know who their therapist cousins are married to. I mean, we live in very, very small enmeshed worlds. I'm going to speak on that tomorrow, actually. So it's not very uncommon that people come to your home, and it really is very off-putting when you feel invaded. I think that makes it hard to stay in a case. So when you said, you have lots of thoughts, you'd like to get out of this case. I don't know if that's part of why you'd like to get out. Didn't you say that? Like maybe I misunderstood you. I thought at the end that you're like sort of exasperated with the situation.
No, the exasperation is more like there seem to be so many things flying around.
Okay, I'm glad you clarified. I'm sorry that I misunderstood that. So I think that when people invade our space in our homes, it really, I think we don't feel safe in the therapy anymore. So I think that clarifying that and how to cancel a session, when to cancel, that they should not. Is your office not in your home?
No.
Yeah, so they track down your home. So, they're not to come over your home at any time. I think that that would be essential. The therapist has to feel comfortable. The boundaries are really there to help the therapist stay professional. That's what boundaries do. They help the therapist stay in your best possible professional stature. So when people come to your home, they've really violated the boundaries and you're invaded. So I think you've got to sort of retake command when that happens. And we all have cases like this. But they've sort of, when patients do that to us, they kind of de-skill us and throw us off. And that's got to be addressed for you to be at your best, I think, also. So it does sound like a very challenging case. But those are my thoughts about it. There's some people here that are more experienced with couples therapy than I am, actually. So I'm curious to hear other people's thoughts about this. Anyone else have comments? I didn't mean to say that you have to be more experienced in couples therapy than I'm just disclosing that that's... I have a feeling that if this couple were in an EFT modality, that the therapy would become very much about the wife's emotional conflicts, and the husband would sort of be on standby. And maybe that would be helpful, actually, because it sounds like she's sort of the more assertive and also the more overtly needy. Like the way it's presented, it sort of seems like, like how can we make this marriage more fulfilling for her? That's what it sort of seems like the frame is. But that's what I find happening with EFT very frequently, is that it becomes about the sort of the more symptomatic spouse's problems seem to like carry the therapy for a long time. It becomes like about the more symptomatic spouse. I don't know if people that have practiced EFT agree with that, but that's what it sounds like to me in the cases that I've heard. So the people saying no in this third row, tell me you're shaking your head no. Franny and Tali are saying you don't see it that way. Yeah. There's a detail that I mean, that I heard, I didn't mention, like, he's starting to worry, can he trust the challah, because when it goes in, so that to me is just like a really good example of when a religious ritual becomes like this, battleground that you can focus on and really avoid what's happening, between the people emotionally. I mean, that's like an example of that. That's a very passive aggressive maneuver. Like, can he trust her challah now? I mean, it's very hostile probably, but there's no, it's all put in like this externalized question. That was what I was, So we'll move on to another case. Who has a case driving you crazy? What'd you say? Yes, there's someone right behind you that we've got two people that... Next. Well, I'm summarizing it, yeah. Did you say you were bored out of your mind? Okay. Right. All right. Well, this will be a fun one to summarize for the recording also. So, 62-year-old woman who, you didn't say this was the presenting complaint, but your presenting complaint about her is that she goes on and on obsessing about what choices to make about the color cabinet. So Ilana Rosen, LCSW of Spring Valley, New York, commented that that's a very important choice, and she doesn't know why that bothers you, but it drives you crazy. And so lots of kind of difficult and nutty behaviors. She has she's hard of hearing, but wears her hair so it obscures her hearing aids. She's involved in an affair. Someone finds her interesting. Actually, that was, as you said that, I was thinking you don't find her so interesting, but someone out there does, and it's who finds her interesting? You find her aggravating. She's very so lots of aggravation, and she also is very difficult to work with as far as medications. She won't let you talk to another provider who's prescribing medications that are causing her to pass out in the ER. So she's really sort of uncooperative, wants to compartmentalize knowledge, not have people know things. Yes? Right, so not cooperate, for reasons that don't make any sense. It also bothers you that she's reading her mother's diary, and she talks about being confused, who am I? Am I myself or am I my mother? Did you say that she read about affairs in her mother's diary also, or? So, and this is a case where you're the psychopharmacologist and you're not working as a therapist, right? And you want to get her to see a therapist. So one of the questions is, what is the diagnosis? I just have this image of her in my mind, and probably a lot of us do. I'm thinking of people that I've met that are like this. There's a very poorly known comorbidity. It's really poorly known even among psychiatrists, but there's a very high correlation between OCD and bipolar affective disorder. There are a lot of manic depressive people that also have OCD. It's very difficult to treat. It's a very high comorbidity, and it's a very high comorbidity among Yidden, actually. And it's very hard to work with. And she sounds like that. Like, she just sounds kind of like, like crazy and all over the place and obsessive compulsive at the same time. And impulsive and erratic, but also obsessional. I don't know. In terms of diagnosis, one of the things that's often difficult to distinguish between is obsessive compulsive personality disorder and obsessive compulsive disorder. The classical distinction is that obsessive compulsive disorder is really about the obsessions and the compulsions. Now, the way you described it, it doesn't sound like she thinks it's a problem that she's obsessing about the kitchen cabinets. She thinks that's normal, like Alana does, right? She thinks that that's fine, that that's a hard thing to so she doesn't see that as an unwanted obsession. So I don't know. So I wonder if she's actually manic, diagnostically, and I would think about like lithium or an antipsychotic as far as medications. As far as the therapy, this would be a very difficult patient to work with in therapy because she's all over the place and spilling all over the place, but it's not clear, like, this is not a person who comes into therapy unhappy about something specific, just sort of is a big noisy storm, and there's always noise with the storm, and you have to sort of like be the one as a therapist to figure out, like, what's not going well in your life, what would be better for you, and sort of convince the person that there could be a more reasonable way to conduct yourself in life and you might be happier. So I imagine that would be, the therapy would be, and we all have cases like this where people come in, it's not clear why they're here. There's a lot of stuff that we seem to think is a problem. They don't think it's a problem. I don't think she thinks it's a problem that she's reading her mother's diary. She's like, fine, you don't like that I'm reading it. I inherited it. It's my property. Leave me alone. She's not interested in that in any way. So there's a lot of things that she does that bother other people and don't bother her. And so there's it would be that, we've all had cases like this. A lot of times people like this are referred by someone else, like they're not referred by themselves. And so I think this is someone, I also imagine, has she been sort of like a disorganized mess, like just a long, long time in life? Has she ever functioned well and in an organized way, or has she always been kind of all over the place? Is it stable? Is this there's stable, there's instability, but there's stable instability. People that are just stably always unstable. It sounds, she sounds thought disordered. So it really sounds like a diagnostic question, like what's the diagnosis? And I would think about mood stabilizers and antipsychotic medication and see if you think she may be bipolar. But there are people like this. They have both OCD and bipolar disorder. We think of them as being sort of incompatible almost conditions, but it's a very high comorbidity and very difficult to treat because you want to use antidepressants for the OCD, and the OCD is more obvious, but it makes the bipolar disorder much worse. So you have to be using antipsychotics and mood stabilizers, and it's just really hard to diagnose. I credit Paul Keck for calling my attention to this. He's an expert in bipolar disorder in Cincinnati, and he's the person that pointed this out to me with a case that similar kind of person that I sent to him for a consultation with about 19 years ago. Any thoughts about this? This is more of a medication case for you, and what would the therapy look like? You had a thought about it? It is. There is something a little bit, just curious about people that have unwanted sexual side effects, but they're having affairs. I mean, there's just something a little bit, interesting about that. And I don't know if it's the sexual side effects in the affair that she doesn't want, not within her marriage, right? But it's not reduced libido. That's not the problem. Yes.
One question I also just want to talk about that women, a lot of women don't have to get extra sex. That's just one. But my question for you is, why would you be concerned about some of the husbands
I mean, we don't understand her. She's thought disordered. I mean, we're confused as a group. We're confused by her. I think that's a sign of her being thought disordered. This is like a manic, like mildly psychotic woman more than an OCD woman. That's what it feels like to me with the diagnosis. Another case? Yes. So just there was a comment that your experience treating a person with bipolar and obsessive compulsive symptoms, and you try to see what is like more thematically essential to the person's core personality makeup. That's how you distinguish between the two. Like, is the person fundamentally, the way they live their lives and the way they're organized interpersonally, is that more bipolar or OCD? And now you have a case that you're going to separate case. Okay.
I'll elaborate on that in a moment.
that when he comes to his sessions, which he basically resists, this is the problem, this is my basic question, is that he doesn't accept the fact that it needs to be seen on a regular basis, which I would actually claim to be once a month, as opposed to say coming every 3 to 6 months or even a year, if it's just that I'm going to review the medication. When I say to him it is true that for medication purposes that he might be able to sit as frequently, but I have to see him in person, and I do feel that many times personal issues can affect the bipolar condition. And that aspect, that personal treatment can affect the bipolar condition, is the issue that he strenuously resists to the point that he questions why he should be seen by me on a monthly basis. Okay? Now, his response to the fact that he has that personal issues may affect the bipolar condition is that what gives me the right, where do I come from on the basis of my training to influence or to affect his personal makeup, inasmuch as my training has been from a secular background. He insists that the only treatment for a mental disorder has to be Cobra-based, on the basis of one who comes from the Cobra background and utilizes Cobra thinking exclusively. And what happened is that over the last several months or years, our meetings have basically been discussions over the diagnosis of bipolar and and what's my approach versus what his approach or the other approach is. And as recently as the last few months, we provided with a source of Cobra psychodynamic, which I've never heard of before. From a Rabbi Yitzhamar source in Israel, who said is this line what's your approach in summarizing in this statement? Okay? So I'm rambling, but my point is this, that I feel, and I will elaborate in a moment about the dynamics that I see are important for him to be treated for, but the point is that he is resisting them. What are the dynamics that I feel are important to him? He comes from what we call a modern Orthodox background. His parents are lyricists that both have very strong film background. His father maybe from a Hasidic background, a brilliant mind, got a PhD from Rockefeller, an MD from Einstein, and he's a practicing neurologist, and very brilliant, very observant, but he has had issues with his father going way, way back. He has issues with his father, and which is carried over to issues with authority figures in general. So that he had issues with the rabbis, he got his money from Rami, he had issues with them, he had issues with other rabbis since when he was working with. But he does have one rabbi that he put from, at least for up to 5 years or so, this is his rabbi. And that's the source that he uses to justify the difficulties that he had with other rabbis that authority figures. Working in the full community, especially in the day school, organizing the day school, he had difficulties organizing issues, not only of a learning setting with the yeshiva boy, he had issues with the leader of that program. He had at least three episodes of issues with authority figures in the period of time that I had. They're very hard issues to touch.
No, just so I want to at some point, any other essential, you've given us a really rich presentation, any additional details you have to tell us, or have you given us enough to start to think about it with you? Right, so now I wish I followed Malky Schick's advice of having people speak into the microphone, because that was a really good presentation. I won't do justice. So he is a young rabbi, you said, with bipolar disorder and OCD features. There have been questions about a diagnosis. People thought he was schizophrenic. You don't think so. And essentially, you can't get him to see you regularly enough. You need, do you think, to see him minimum of monthly in order to continue working with him. And he doesn't want to be seen monthly. He also objects to being treated with modern psychological, psychiatric techniques. He believes that there has to be like a Torah-only approach. And you see that there is a definite theme over the course of his life of conflicts with authority figures that he needs help with. And he's acting that out with you, actually, in the therapy. Like, who are you to tell me? So you're another. You said there's three, but there's really, in the therapy, he's bringing this same issue. He's acting it out with you as well. So a few things to comment on. The first thing is just, in general, it sounds like you have a really rich and integrated understanding of him, psychodynamically, diagnostically, biologically. So it sounds like you are on top of the case, and the way you formulate his developmental history, his family background, it sounds very plausible. Like you tell a compelling narrative. I just want to emphasize something. There are a lot of people who are. The diagnosis of schizophrenia, in my history as a physician, I'm watching psychiatrists become unable to diagnose schizophrenia properly. And I don't know why that is. But there are a lot of people who have schizophrenia and they have a clear lifelong deterioration in social and occupational functioning. And that's what schizophrenia is about. Schizophrenia is not about delusions and hallucinations. In the active psychotic episode, people can have delusions and hallucinations, but schizophrenia is like about not showering and brushing your teeth, and not having good eye contact, and not doing your laundry, not being able to keep a job, and becoming more and more disagreeable, and getting evicted from lots of apartments. And it gets worse and worse every 3-4 years. It's worse and worse, and it goes on for decades and decades. And it starts with usually paranoia, not paranoid delusions, but just, being suspicious and never being cooperative and always thinking people are interpreting things in the worst possible way. And there are lots of cases of schizophrenia that are not being well diagnosed, primarily, I think, because people are on antipsychotic medication and it's stopping them from getting psychotic. On the other hand, there are patients that are like what you're presenting, where people become floridly psychotic in the middle of maybe a manic episode, maybe a drug-induced psychosis, and they're seen in a hospital and diagnosed with schizophrenia, and once it's like in your medical record, can never get it out of that dang medical record, and it sticks with them all the time. So it's really important what you've done to understand he doesn't have schizophrenia, he has bipolar disorder. And it's a real problem in mental health now, is the missing schizophrenia and misdiagnosing schizophrenia. I don't know why this has happened, but we need back to the basics with diagnosis. So Malky has a... Yes, I think...
moderating what would otherwise be psychosis, because actually people are using that antipsychotic for anxiety, or they're using...
Yes, I think so. I think people on atypical antipsychotics have less florid exacerbations, so it gets unrecognized. But I also think people just don't know how to diagnose it anymore. They know how to diagnose... People in the hospital last time, people used to be in the hospital for months. Months and months in a row, like in the 70s and 80s. Months and months in a row. When did you train? When did you finish your training? What decade? Just tell us. In the 60s. I mean, people that are training nowadays, they meet people for 2 days in the hospital. They really don't understand what it's like to see someone, stabilize someone, and then see them as an outpatient for a year or so after. Like, that kind of training is disappearing, unfortunately. So people just don't know the disorder, I think, the way they're trained. They just don't really understand lifelong disorders. They don't get it. It's a shame. So there's a lot of, so you've got the diagnosis properly, like I'm sure you're right. The way you describe it sounds exactly right. So what you're really describing now is the transference. I mean, he has a transference. So, the definition, what was... Yes. Well, he has a personality disorder. Although I think he's still manic and psychotic. That's one of the things I'm suspicious about. But, a personality disorder is someone who has pervasive problems. This is actually the most important. My favorite page in the DSM is the general criteria for a personality disorder. Do people know what this? So it's not. You have to have the general criteria for a personality disorder before you can have a specific one, and it means you've got two or more of the following 4 problems that are pervasive in your life and interfere with functioning or produce a lot of subjective distress. So, interpersonal relationships, impulse control, the way you see yourself, they call it cognition, which means the way you see yourself and understand your place in the world, and affectivity, which is the way you react to stress or new situations in your life. So, because this guy, I think, is not really still stable, I suspect he's not maybe stable with his mood and still a little psychotic, possibly. I don't know. But I don't think do you feel his mood is really stabilized, or he's always kind of edgy and in a hypomanic, irritable state? He sounds like a feisty, irritable character.
Yes and no. He's very smooth and deliberate. The few times that he's been semi-impulsive, I've taken to be signs of hypomania, which is where, in conjunction with his wife, he cooperates, and his final outlook in terms of deciding.
Is he manic or not? Yeah, I think that's very helpful in bipolar disorder. You need to stop this. Right. 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 So just a couple things about that as well. So I'm going to talk to me before the conference is over and give me your email address. I'm going to send you a link for a lecture by, is it Rabbi Lopansky, the rabbi in Washington? Rabbi Lopiansky. So he has a really interesting lecture he gave, and he talks about the idea of Musar being used in mental health. And he says something that I found, really exactly right and very helpful way to phrase it. He said that Musar is to take a very healthy person and make him into a righteous tzaddik, a great person. Musar does not take a person who's impaired by mental illness and restore mental health. That's not what Musser accomplishes. And I listen to it and see if it would help your patient to listen to this, and share with him, your thought is that the Torah helps people who are mentally well achieve tzidkus, as opposed to helping people who are impaired and off balance gain balance. And there's a lot of confusion about that. So I think it's helpful to show patients like this your respect for staying in your lane and not staying in and not interfering in another person's lane. Does he have a rabbi that he defers to, or not really? There's a rabbi, so that might be. I don't know if that would be helpful to involve his rabbi into the discussion. But another thing, just in terms of understanding what transference is. So when patients display their personality problems with you, that's what transference is. Transference is the way that people bring their emotional problems that they have in every area of their lives, and now they're acting it out with you in the therapy. That's what the transference is. And so one of the challenges is at best you're trying to see him once a month, so it really isn't going to be enough contact with him to do therapy. You can have some therapeutic maneuvers, but you're not going to really. So I don't know if being more ambitious and trying to do real psychotherapy with him on a weekly basis is a possibility, or he'll never go for it. But he doesn't understand why he needs to see you regularly just for medication adjustments. But I suspect that he's probably still more manic. There's something about the energy with which he's resisting. That what I really need is Torah. I need help in a Torah approach that sounds a little bit psychotic, like more than just cultural. And he's not from such an insular background that he'd be, opposed or paranoid about secular psychology. I mean, he has educated parents. His father's a physician. So it doesn't sound like you're not treating someone from Meisharim or something like that. I mean, you're treating someone who's had a general exposure to the outside culture. So it sounds to me like he may be still paranoid and psychotic, but I think it's a very interesting case. Fran is looking confused at me. Share your thoughts, Fran.
I know, obviously I don't think that well, but I have a little bit of a different approach, name that, which is, first of all, I think of many people, either in the modern Orthodox world, that got diagnosed several times with schizophrenia, bipolar, it could be hard to accept that, even whether it's true or not. So he's obviously resisting that diagnosis, so I guess I have two thoughts. One is there a way to reframe it to make it more amenable to hear that? So maybe using different kind of words or a different way of speaking about it, so it's not bipolar. I mean, there's some reaction he's having to that name. So again, I think how to reframe that the way you need to hear. And the second thing is I think when you're quite resistant, it just gets worse. So like sometimes going with resistance is a good way to go. So it might be that I study a lot of Musser. I actually think it's super helpful psychologically, even for people that have more serious illness. Not as an only treatment, but what would it be like if they learned, a passage with Musser together as they talked about medicine? Again, the concept of going with resistance and reframing this in a way that makes it more amenable to that existence.
Right. So yeah, I mean, I don't disagree with you at all. I do think that when people don't accept the diagnosis of a major mental disorder despite serial hospitalizations, that it is often untreated psychosis. I really do think that's the case. I mean, he's been hospitalized how many times? But I mean, he was floridly psychotic if he was hospitalized, right? When he was hospitalized? Yeah, so if people go through florid psychosis and I do think that there's probably untreated psychosis still. I mean, that's been my experience with people that have, major psychotic affective disorders. If they still don't believe in the diagnosis, that you're still dealing with mood instability and psychosis probably to some degree. So in terms of resistance, resistance is just simply whatever the all of us have things in our lives that create emotional discomfort, and we have ways of dealing with that emotional discomfort that can often be ineffective, and that we're not able to just embrace what the issue is head on. So resistance is simply when that happens in the treatment, that the encounter with the therapist is very uncomfortable emotionally, and it's someone who is, it's a defense against whatever the emotional experience is of that interaction. So his resistance seems to be, number one, to defer to your authority. There's resistance to that. And number two, the diagnosis. Being diagnosed with a major mental disorder, for most thinking, intelligent people who value their minds and their autonomy, is a major narcissistic injury, being diagnosed with a major mental disorder. So I think you're dealing with someone who, underneath the authority conflict, sounds like he's narcissistically vulnerable, and it's a way of, turning the tables or evading your authority or disempowering you. And really, a lot of authority problems are, especially when people won't accept and rebel against authority, there are a lot of narcissistic personality issues that are tied to that usually. I mean, that's a very common symptom of narcissistic problems, especially in men. Also in women, increasingly now in women, as women have more avenues for success and achievement in our society. But a lot of young men that really, it's a very common problem with narcissistic young men, is that they're very, very resentful of authority. So I think that this has been a major narcissistic injury for him. Does he function? Does he have a job, or can he earn a living? He loses jobs. That he's better with subordinates than superiors. Look, that's how each Muslim movement started. Yeah. Yeah. It's surprising that he could run a cola. I mean, it's surprising that he can even do that based on the way you're describing, but that's an interesting case. What is the, how are we doing on time? It's, and what is the end time that was set for us? 10 o'clock. Okay. So why don't we take a 10-minute break now, and we'll start again at 25 of. Shalom Aleichem. Nice to see you. Yeah, go ahead. I got this one before. Yeah. What? Oh, you got a case? Yeah. He gave me water before, so hanging back.
I got some threatening voicemails from the person's husband. I blocked the number. I blocked the WhatsApp. I blocked that. It's been a couple of
Let me turn this off for a second, because this is going to be recorded. I don't see a switch. Okay, so, all right, so there's a lot of stuff here. All right, so since you only gave me like a condensed, of course, version of it, I might say a lot of things that you know already, you've already thought about, so I'm not... Okay, so the first thing is that I do want to think about her diagnosis and the formulation. So she has Axis 1 diagnoses of bipolar disorder and maybe PTSD. Okay? Okay. Now, I think that there's a pattern of people fighting over how much influence they have over her. Like you, the rabbi, and the husband are all fighting for who is the one that determines, like, you know, who gets to help her and who's in charge. So, you know, you're probably the most balanced and respectful of her autonomy of the three of you, although if I heard the rabbi present this rabbinic, you know, at a rabbinic conference, he'd make you sound bad too. You know what I mean? Like, but there's three people that are like fighting for control over her life, I think. And now the rabbi's not in it. He's not involved now, but he's not involved now, but he was very involved. So I think she does this. I mean, I think this is something she does. I think that she pits people against one another in some unconscious way, and that's part of her dynamic, is that she has people fighting over who gets to be in charge of her life. And, you know, so the way you're describing it, like, you know, the husband won't let me call this person, the husband won't let me call that person, but it's really up to her. I mean, like, he can't... I don't know what that means. Who do you want to talk... Well, he's not your patient. He's not your patient, right? Yeah, so I'm not sure. I mean, I don't know what that means. I mean, if she wants you to help advocate for her with someone, I mean, it would be a weird thing to do anyway, because it really should be her. She can talk to whoever she wants to. Really, you're talking to this person on her behalf is what she's asking you to do. But the idea that, like, you know, the husband has to let you do this, I mean, like, this is... But that's, in other words, she's getting you to do this for her, but then he won't let you. So, like, she's getting... It's the same thing. I think that she's getting people to fight over who's in charge, like who's driving. Like, she's a passenger, and like, are you the one driving the car that she's in the back of, or is the husband driving the car? He's like, I'm the husband, it should be up to me. So I think there's something about her that does this, you know. Now, their marriage, like she's an unstable character to some degree. So he married her to maybe care for her. This is something about the dynamic of their marriage. It's like a codependence of some type where he needs a sick person to care for.
He's like amazing when she hospitalized. That's when he becomes super.
Right. But I think that that's part of her character also. Like, I don't think that's only when she's psychotic. Like, I think that she becomes what you're describing, like she becomes sort of helpless and people have to do stuff for her. And then they conflict with one another. I mean, the rabbi's out of it now because the husband got him out of it. Now the husband's trying to get you out of it also. But I think there's something about her character. Like, this is, I think, a symptom of her character disorder. I think she has. Now, I understand she's a very likable person. You care about her. She feels benign. But I think this is like a passive aggression by her. I think that she gets people fighting over her. Like, I'm remembering a case I had in residency where there was a woman who was so beautiful. She had lots of men fighting over her, literally fisticuffs over her. And she tried to get me to hang out with these other people. And like I was going to be there, and they wanted to know what's going on in the therapy. Like I was going to be another man fighting over her. And so it's something. This isn't a romantic, but there's some sort of like she gets people to kind of take over her life in some way. So I think there's something like dependent personality, but it's more complicated enactment than that. So I think that's like part of what's going on. And so I would think that the treatment has to, it would be very hard to do, but I think it would ultimately have to be that she's kind of in this like sad, post-traumatic, unstable mood state, kind of like pulling the strings on all these adults, making them fight with one another over her. I don't know if that happened when she grew up with her parents. I don't know what the origins of this are, but this seems to be like how she operates in some way. I do believe that any intense therapeutic relationship where the therapist becomes either the most important or one of the most important people in the patient's life for a while in the therapy, I think that it's only a remarkably healthy spouse that doesn't feel threatened by that. And he doesn't sound remarkably healthy. He sounds like really fragile. So to me that feels like an inevitable liability when you have like a controlling, enmeshed husband whose job is to care for the sick spouse, that he doesn't see you as an agent. He sees you as like having too much influence and disempowering him in some way. So it just feels like a setup for that. So if there's you've tried to involve him, but I would think involving him and maybe, having to say very frankly to him, well, listen, I hear you saying that you want her to have sex with you more, but, that's not how therapy works. You have to tell your wife that you want her to have sex more, and she can bring that into therapy as a complaint, but, like, I cannot do this. To have some sort of way of having, like, a very frank discussion with him about it that isn't hostile, but like that, you're really respectfully listening to him. But I think of like marriages or rabbis or relatives that like I've become more and more willing to let them in on the therapy to some degree because that's the world that the patient comes from. Like these people are in their lives and you just can't really like make the person autonomous for the therapy. Like they're not autonomous and so I do meet with relatives and important people more than I used to in the therapy. I just do it more and more now. I find that I need an alliance with those people in some way. And I find that you can get an alliance if you talk very honestly about like, well, this is why I can't do that. That will be harmful to her for the following reasons. And just like kind of explain it. Like, you might try doing that. I've never met him, so I don't know. But I just, in general, like anyone I see where parents are paying for the therapy and it's an adult child, I do meet with the parents. Like I meet with the parents probably quarterly forever in the therapy. Like on and on. If they're paying a lot of money, especially for analytic treatment or something like that. It's a huge investment and they're paying for it. And like, I just feel like they can't, this kid isn't, this adult is a kid still, and they're not autonomous yet, and so they are involved. So I really need their buy-in literally their buy-in, because they're buying. I mean, they're paying for the therapy, and they have so much influence in the person's life. So I'm more willing to let people have some presence in the therapy. And then, wanting them to be more autonomous is a goal of the therapy, but I don't feel like it's an enactment and I'm giving them too much access. I think actually it makes it much easier. If I get them to understand and trust the work I'm doing, I find it's easier to do. So if there's some way to have the husband trust the work you're doing and understand it better, you'd have to figure out how much you can share with him, what's safe to share with him, how really, is he acting in good faith or not in good faith. But I think you're probably stuck with him more than you want to be, because she will not, until she's much, much healthier, she's making him fight with you. I think she's doing that. And it's unconscious, but that's... I can't hear what you guys are saying. Well, I
she's contact, and I feel really sorry for her. And I also feel like, she's the identified client. She's the client. She's the one who's ill. She's the one that takes care of her. But he's got a lot of distress. She's not in distress that they're not having sex. He's in distress. So first he's okay, but not as much as he wants. Okay. So he wants more. He's distressed about it. Okay, but if he's distressed about it, then he's the one with the distress, not her, in this area. And the idea of how much control, what they say in the Bible, you marry what's the woman. And, she's never had a development of autonomy. So of course she needs friends to protect her. She doesn't have a voice. I think that the treatment is about empowering her. And exactly what you said before about what is the reason you make her leave, that was clearly everything is coming to disappear. And I just trying to understand more about what is so scary about that, what would happen to her.
For him you're talking about, or for her? If she would...
I don't think that she's enjoying that he controls her.
Well, so to me the definition of let's just think about what passive aggression means. So passive aggression is when I'm unaware of my aggressive impulses and I'm using unconscious mechanisms to basically discharge my aggression in some way. So the most common ways we think about it are I forget to call you. So I'm, ignoring you. I'm basically standing you up for a phone call, but I'm doing it without knowing that I'm doing that. So I actually, reject you. It's rejecting to not call you, but I don't own it. I'm mad at Franny and I'm not going to call her and I didn't call her. I forget. That's the classic. But I think that when you say, what does she get out of it? I don't know because I haven't evaluated her, but people get all kinds of things about having other people fight for them. The first thing is I think that she is getting others to act aggressively, and I think that her aggression is expressed through other people fighting with each other. That's one of the things that she gets out of it. It's very unconscious. This is very deeply unconscious, so it isn't pleasurable for her consciously in some way. But I think that she's, and I think that he's also not autonomous. He's also not an autonomous man in some way, in many ways. So I think that's what I imagine she's getting out of it. I think she's terrified of her anger, terrified of what will happen to her if she says no to people, terrified what will happen if she asserts herself. I think she's also inept because she's unstable with her traumatic symptoms and her affective disorder. So I think she just may not really even be able to, say no to someone. Like, she just really doesn't have it's not just emotional. She may be also lacking the cognitive and affective stability to be able to do that in some way. But I think that may be part of what she's getting out of it. But I do believe that she's doing this. I mean, she's there, and she finds people that try to take care of her and try to take over her life, and then they get in conflicts with one another about it. Like, that's a thing that she really is doing. And so I think you're part of that, because that's how pervasive and effective she is in some way. There were a couple other things. So if you could get them into a family, a couples therapy, but it's like family therapy, it's like the whole. Do they have children? And what is the parenting like between them? Do they collaborate? Is he in charge of everything? Do the kids go to her, not to him? Like, what is or don't you know? Right. I mean, I do think he's a threat to the therapy in a lot of ways. And if you can't have an alliance with him, I don't think she's healthy enough to stick with therapy without him. Like, she won't do it without him. Like, she's letting him break up the therapy in some way. So that's the only way I can imagine salvaging it, would be if you can have more of an alliance with him. It can't be that he gets, to veto stuff in the therapy. You'd have to really just honestly explain why that can't happen, and then he can still sort of take it or leave it. But I think that's, you are stuck with him. As long as she's stuck with him, you're stuck with him. The degree to which she can't leave him, neither can you, I think, in some ways. Well, sure, you can. We can all, become jugglers or comedians or something instead of doing therapy. I don't know. What do you mean? How do you remove yourself from being? Does he want you to stop treating her? He wants you to stop. Right. Well, she might.
She doesn't want me.
No.
She feels like whoever she sees is going to happen.
Yeah, and that makes sense that would happen in that way. Yeah, I mean, look, in some ways that's what the focus of the therapy is. Is it going to be like, what are you going to do about him? How are you going to deal with this? I mean, that's another therapeutic stance, is to sort of like not, just to really keep it in her court. I mean, he's a third party. It's very hard for third parties to sue a therapist. It's. Well, you mentioned that you feel unsafe with him. That's how you get out of it, is you just charge your regular fee. Is he violent to her? Yeah, it sounds like control, like the rabbi. And he... Okay, but see, that to me is really, I mean, I am skeptical about, like, that. She's really colluding with that. She really is colluding with that. Like, that's very, very crazy, not just of him. Like, that's crazy for her to go along with. It really is. But in the scheme, but we all have patients with crazy spouses, and it's a very small number that collaborate to that degree. Like, this is how she's doing it. She's afraid of his anger. I think she's afraid of his anger. That's what I think.
Well, I mean, I told her that that's just not in Pennsylvania, it just doesn't happen. There's joint custody, so it's just not going to happen.
No, with her actually, it could happen because she would never assert herself in court. In other words, like, she would go along with that. You know, that's like, I think she's pathologically compliant with his control. I mean, that's why he married her in a lot of ways. Like, I think that's I couldn't hear what you were saying.
Working on the early trauma of the father, which we have so much trauma. Yeah, it's hard to say. Yeah, she's not in a safe situation to really do more trauma. What about continuing support? Yeah, I agree.
I think her fear of what will happen if she, so I have a patient right now that was absolutely terrified to say anything to her husband at all, and he was very controlling about the therapy. And this is more severe, but it's close. And what she was afraid of, she imagined him screaming at her, and she would sort of crumble into become like a jellyfish and kind of just like collapse on the floor and want to die. Because that's how she feels when people yell at her, they're angry at her. And so that's what I'm sort of like imagining, like that's my kind of projection or fantasy about your case, is she's terrified of his anger. She can't tolerate if he's angry, and he gets very angry if she won't do what he says. So like her inability to tolerate his anger and to go along with it because she's so terrified of what that will feel like. And I think that's another thing about this case, is that it's not that she's afraid of what he will do. That's what her rationalization says, is that she can't tolerate how she feels just imagining saying that. Like, she can't tolerate how she feels when it's not what he'll do, it's how she'll feel when he's angry or when he's bossing her around. Like, she's afraid of how she'll feel in that scenario. And that's what is controlling her. And that's why I think she's very passive in her aggression. Like, she can't, and I think that on some level it's that, that fight, that clash that she just cannot tolerate in any way. Maybe she's afraid of getting psychotically depressed again. Maybe she's afraid of having PTSD symptoms. Maybe she's afraid, but there's some emotional, terrible discomfort. And that's, I think, the formulation piece. But I do think that's ultimately her problem. So you're like, she gets people caught up in advocating for her, talking to people for her. Like, that's kind of what she's got you doing. And so maybe that would be the other. One approach is try to get him on board more. The other, you don't seem to be hopeful for that, but I don't know how you can avoid that. But also to like pull back and say like, well, what will happen? Like, so what is this, if you don't give him the report of our session, right? She wants to know he wants her to record the session. Does she want to do that for him, to make him, but she reports to you that, or he calls and says that? But you're the one that said we're not going to. Okay, so let's think about that. That's okay, but she brought a tape. Okay, here's the thing though. She brought a tape to the session. Okay, she took out her phone to record it, and you said we're not recording it. And then you say, no, we're not going to. Okay, so let's just think of technique for a second. What if you did this? Let's do a little role play. Okay, so I'm you, and you're this, whatever her name is. So,
My husband wants me to record the session. I know it's ridiculous, but like, whatever. He's like so paranoid about everything. He wants me to record the session.
oh, so how would you record the session? What would you do? Why don't you want to? But you don't want to because he tries to control everything? Or you don't, I mean, why don't you want to record it? When it unfolded, you had to say, no, we're not going to do that, right? So, like, that's... So I think of it as, in more than countertransference, I think of it as more like an enactment that she's getting you to be the one that says no for her to him. But that's a global technique in her whole life. So that's what I think is really maybe the most powerful thing to work with in the therapy, is that she's getting you to be her advocate, and then like you're getting in trouble with everybody because she doesn't want to get in. Just with him. Okay. Well, who are the other people that you're supposed to call? I mean, right. I guess that's what I would add to it, is that I think she gets people to, if someone would cheat, let's say that she'd go to a store and she'd get cheated out of something at the store, he would call and take care of the whole thing and get the money returned or get the item returned, or she would do that herself. If she were healthier and more assertive and could own it and handle the pushback, do you think she'd just have to divorce him and be able to, or do you think that he'd change? Or don't you know? So it's sort of like the ideal outcome would be she'd be more assertive, and then either he'd accommodate and change, or they'd get divorced, but she'd land on her feet. Like that would be, and not, it wouldn't be, like that would be the sort of, you'd have to see what he would do. Something would have to be very different. Either he's not married to her anymore, or he's, changes his stance in the, yeah. Well, I don't know if that would be helpful. You said you'd be very happy if anyone can help you. So what are other people's thoughts about this? David, you were saying the safety. Were you thinking of violent? What? Oh, then no, you're not allowed to talk then. Go ahead. But what's the threat, though? What is the threat?
then there could be a lot of situations. And if you look at pathologizing the victim,
Now I'm like the next one.
it may all be accurate ultimately in her work, but at this point it's pathologizing the victim. It's not helpful for her in this context at this point.
Well, what's not helpful though?
Doing exploratory, insight, change-oriented work with her in the context of the victim.
I think both.
Because I think most people on a capable of that are not going to fit. You're asking her to do work on interchange, and it's not going to fit. I don't know if people are capable of doing that.
Every dynamic is a dynamic, even when there's domestic violence, there's somebody on the other side who's putting up with it, or who's owning it. So interchange is, becoming self-aware enough and able to identify enough.
I think that the way we can help them do that, though, will be by naming the abuse for what it is, identifying and helping them normalize their approach. That's a different approach.
Well, it's definitely a different approach. I'm with you.
Yeah, I think that's why it's possible under
But
that context.
you still have to do insight-oriented work with her as you're identifying. At the end of the day, people don't have the choice to change their partner, but they
But it's a complete reason. It's not from a pathological perspective. It's much more of an appreciation of what she's going through and what she's challenged with and helping her work.
Well, it's, and we're going to get to you in a second. It's interesting because this is often, like the exchange I'm having with David right now is often, I think when I'm consulted in cases, this is frequently my, it's a similar like disagreement to this one, whereas that I tend to see the patient as having more potential power and being more involved actively in a hidden, passive-aggressive way. Well, I see the person as doing more and being more of the, I mean, you're calling it a pathological perspective, but or blaming, but no, to me it's more like I have hope that people can actually, they can actually take control of their lives more. And I do see people as being really instrumental in setting up the impossibilities, like the impossible situations that they're in. It's just a frequent disagreement I often have. Like the way you've presented it, I see her as, I imagine this isn't created by this scenario. I think that this is pre-existing before she married him. That's what I'm going to be very curious to know, but I imagine that this was a pre-existing personality style that she had beforehand, and that they were kind of like a shidduch made in heaven in that way. Very, very passive, inept, passive-aggressive person with a very active, controlling person, and that's how the match was made, and that ultimately she will have to be the one to do it. And I don't think we can, I don't know that we can stop him. Like, he won't go to therapy, he won't. I mean, that's the alliance. When I say making the alliance with him, that would be my attempt to try to change the dynamic. But I think ultimately it's going to be up to her. Like, the ball's going to be in her court, I think. She's the only one that can really stop this, I think. The rabbi being involved too is also like when I know he's not now, but like her, it makes me think this is like what she does. But you had a question or comment. What slack are we cutting him? What do you mean?
I mean, the way that your concept kind of started it was everyone that you kind of put in that as a sister, reaching out and really close relationship with them, speak to really good support and to kind of pressure out. And he's almost like spinning people against her. And I almost felt like we were almost like being considered this competition. Like, there was like a lot of, like, well, here that they don't use it as opposed to
But what are we going to do about that with him? I mean, he's not a partner in this right now. Like, he's not, like, she's there for help. It's not that we're cutting him slack, but we don't believe that we can really get him. Like, I think Franny has tried to do what she can with him, and he won't go to couples therapy. He is, that's just what he's doing. So we can't, she's the only one. She's the one on your couch. That's the issue. What did I see her as perpetuating it? Well, like I had said before, I see her as getting people to advocate for her and then conflict with one another about it. No, I don't think he's leaving her. He needs her. That to me that's like the fundamental thing she can't tolerate. That's like his weapon. She can't tolerate his anger and aggression. And why? I mean, what's going to happen with it? And so, what's that? Do you say we can or can't? Because we don't know what he'll really do. Well, the reason that I think she can tolerate more is that she has stayed in this relationship with you for 2 years. I mean, she's sticking it out for long. I mean, it's a long-term treatment already with a lot of conflict. So I think she wants you, the enactment is that you're doing that for her. You're the one. And so I think that would be, whether you can. Yes, definitely. Right. That's when you say the countertransference, that's like what's getting, I call it enactment, but yeah, it's a projective identification. So I think that she ultimately, it does come down to her, and I don't know how to stop him otherwise, other than making an alliance with him. But if you don't believe you can, then it still gets back to her, or both. So that was a great case for us to discuss. So we've got about a half hour left. I think we could do at least one more. Yisrael. Has she been evaluated yet?
She just started therapy, her own therapy, and she's also starting therapy now for like the first time. So it's still early in the in therapy. I can't. I don't know. Like I told him, like, there's nothing that we can do that will change what your life is. Your life is acting, but we can kind of work on things that you could do to help cope, and how to how to help children suffer less, and how to be the best person you can be. But like I'm kind of lost of like where to go next for him, just because like I know we consulted on another case where like the spouse is the Luke Cannon. But he had more of his own issues with the client. But like here, it's like, okay, he has some issues. I don't think they're anywhere near like an extreme. Again, like she could be presenting about him something totally different. I have spoken to her, and he wants the time being to like keep my therapy with him separate and her therapy with her.
It's a Hasidic couple?
No.
Not a Hasidic couple. Okay. Well, I mean, you gave a very clear presentation. It seems like maybe what's happening is that he is really at a loss for knowing. Like he feels like just completely sort of like a deer in headlights with his wife basically devolving and having like nervous breakdowns every time he leaves the house, or terrible panic attacks, or I mean, I don't know if she has out of control panic disorder or borderline personality or a mood. I mean, I don't know what her diagnosis is, but she sounds like really ill, and he feels like he doesn't know what the heck to do. Like he's trying to patch his wife together enough that he can just go to work and that she can so I would think that what you're doing sounds so far pretty good, and what you said sounds about right. I think that he's faced with he has to get more information and see if she will improve with some treatment. But it seems like he would have to, if he would divorce, let's just think about what would happen if he decided to divorce her based on the current scenario. He'd still be stuck with, she can't function probably as a mother, so he'd have to be he'd still have, the mother of his children is totally unstable, so he'd have to be like a single dad with the kids living with him. I don't know if he's in a community where single men never live with their kids after a divorce, so that's that's unheard of. I don't know how much in-laws are involved. I don't know. You work in various communities with very different sort of family constellations in the way, so I don't know what their scenario is, but he probably needs to be able to think through and figure out how he'd handle all the possible things that could go wrong. It sounds like the way the therapy's opening sounds about right, but that's what I'm imagining is that he's terrified. I think he's scared. I think he's terrified. So as she gets treated, hopefully things will get better, but look, a lot of people, don't get much better with treatment, unfortunately. So, and people don't agree to go to treatment. We don't know how she'll do with treatment. And we don't know what's wrong exactly. It sounds like a pretty severe scenario.
I can talk a little bit more about her symptoms. She functions in a high-paying job. She's very, high functioning.
Did you meet her?
I never met her.
I'd be very curious to meet her, and I'd be very...
We discussed that. For the time being, we want to keep it separate. I know the therapist that she's seeing, but we want, for the time being,
Right. So I'd be very curious to know, if there's... Would she describe some... I'd be very curious to know, is there some thing that he's not aware that he's doing or hasn't reported to you that he really makes her feel totally abandoned in some way, and there's some other piece to it that he's making her sound like she's really crazy and unstable, but actually there's some marital conflict that he's really either oblivious about or ashamed of, and she's acting out, and there's a more understandable narrative going on that's more complicated. I just want to know the other side of the scenario. So I might...
it's possible that she thinks that he may be on the spectrum. I can see where she may think of how that could be possible, but in my... like you said earlier, how we live in communities where we kind of know each other, so I know his family, and from my experience talking to him, it's kind of, they have this, they're not, I don't know if it's the proper term, but they're not, maybe spectrally, but they're not on the spectrum, but they're very intelligent, but very, I don't think he's on the spectrum. That's basically...
Now, I feel like you can say to someone, listen, we'll keep your therapy separate, of course, but I really feel like to help you, that to have a session, you don't have to be at the session. I will just tell your wife that I'd like her to describe for me what goes on at home that makes her so distressed when she leaves, and that you could, ask that. I don't feel that necessarily means that the therapy's getting messy or the therapies are going to be intermingling. Like, I think that there are times you can say to someone, like, I just feel like I could help you better if I just hear, exactly like what your spouse's version is of all this stuff. But I feel like you have to know it. And then I also think that, like, it would be very helpful, I think, in any way. Number one, it would be helpful. You'll get information about her, just not that you're going to do a diagnostic evaluation of her, but you'll just get, you'll form an impression of her in some way. And something is really, either she has a major mental disorder, or he's a very limited historian and he's missing important parts of the situation. I would ask to meet with her, and I don't know. I mean, I don't have that many people tell me no, I can't meet with the spouse. Like, I don't really, I don't ever have that happen.
I'll bring it up again. I was only the first session, because it was like a group practice setting.
Yeah.
But I will bring it up again. And in terms of like having more children, so she went off birth control recently, and her argument is like, you don't have control over me. Like, it's my body. This is my decision. What? Right. Yeah. And and he said, like, you there's no, you can't argue with her. It's like, she gets very emotional and there's no logic in their discussions and arguments. But he's just like worried, like, okay, another kid, like, what can we do for her? And like, this kid is gonna have challenges, and he doesn't know what to do.
Well, but she's not. I'm just. What kid? I'm confused at the end. Last.
Like, if she has a new kid.
Oh, well, so she's. You're saying if she stops birth control, or? Oh, she stopped birth control. That's right. He wants to continue birth control. She went off birth control. She went off birth control. I misunderstood. Okay. Right. So that's. Well, look. That's a couple's issue. That is a couple's issue. I think you need more information. And look, I could imagine someone who's sort of on the spectrum describing the marital situation in a very kind of oblivious, limited way, and it might sound like this, like that kind of, like, you might find that out. A lot of us were not trained. A lot of us were not trained to, like, identify autism spectrum disorders very well in our training. We were not trained with it very well. It's like a relatively newer diagnosis. There are mental hospitals full of people for many years that were diagnosed with schizophrenia, but they don't. They have autism. There are people that were diagnosed with profound mental retardation and thought to be sort of like vegetables, but they actually have autism. We're not really very good, actually, in the field at identifying autism spectrum. It's actually difficult to diagnose, and a lot of us were not trained in it. It wasn't a prevalent diagnosis. And when you talk to someone who's on the much higher functioning, end of the spectrum, you don't necessarily notice it right away. It just comes across as sort of like a flat style, and people can be very verbal and communicative, and it takes a while. I think there are a lot of situations. So if it's interesting, I would be interested to hear why she thinks that he has autism spectrum. I have cases, I have people in my practice right now where the two husbands, and the wives are both insistent that their husbands have Asperger's or an autism spectrum disorder. And I'm really not sure. Like, I really can't tell. Like, I know what they see, but it's hard for me to really exactly. And I think I'm a pretty good diagnostician. I think it's a difficult diagnosis. I don't know what other people think about that. I don't think we were well trained in it.
The question is, what's the matter? Meaning, if on a practical level, the issue is that he's struggling to connect emotionally or socially, then you address those issues in terms of teaching him ways to do that, versus focusing on the diagnostic in terms of if he's Aspergery, then, like, what does that mean on a practical level? Who cares about that? What does it mean? Does it mean that he...
Well, not like the way he's describing the situation.
No, I think it makes a difference in a lot of ways. I mean, the first thing is that it's whether you see someone's emotional disconnect as a deficit model. If it's a deficit model, you're trying to like teach skills and give a lot of psychoeducation. But if you see it as sort of like an obsessive compulsive problem, then it's not a deficit model, it's an emotional conflict. So the whole way that you would understand their disconnect, or there's an avoidance of uncomfortable emotions that you're going to treat with a conflict-based model, versus someone that like you think is really like missing some of the equipment in a neurologic way. You have very different expectations about what's going to happen in the relationship. You talk to the spouse very differently. I mean, it's a very, very different treatment. Your prognosis is different, your goals is different, and what you're aiming for is, I think, different in the treatment. And then what you were starting to say, like, if you think that the person has an autism spectrum disorder, that's really your judgment, you frequently cannot trust their report about like what's happening, and you're going to have to get lots of collateral information from the spouse over and over and over again. Like you're dealing with someone that is basically doesn't have the antenna out to read other people's emotional states, and it can be difficult, I think, to determine. It's like not super clear. So I think it makes a big difference in those ways.
They lived out of the country for a little bit, and things seemed better here, but there was always a certain amount of, there was always like a little bit, but since they moved to the States in the last couple of years, it's gotten worse. So no, actually, her family seems to be a stressor, like her parents. Or the state seems to be a little bit private, third something. And, her mother meddling and whatever, but it seems to like make things worse. At least when they were out of the country, it was better. And I asked him sometimes, sometimes it's still in the case, but like he came this something yesterday, and so how's the week? He said, it's actually a good week, and he said like times like this, it's like I don't like the report. It's like it's so good, just a regular, just had a good, a good time.
It's weird. Yeah, that sounded insane when we first heard that. Like she sounded psychotic. Yeah, something doesn't add up for us. Now, Dvora, you were saying, what does it matter? I cut you off to tell you what it matters, but tell us more what you were saying. Go back to your... So the piece you missed, is that he presents describing his wife basically like losing her mind and going totally insane every time he goes to work. So, and so sometimes doing that. So let me just Yeah, well, I want to try to let me rein everyone in for a second. We're scattering a little bit. So let me say something then. So one of the things that's going on is what we're doing is so Alana just said, well, is he leaving? And maybe this is not true, but that's not the point at the moment. Is he leaving at bath time? Is he leaving when it's like, is he leaving at ridiculous times that it would make anyone insane to do that? What Alana is doing right now is Alana is mentalizing. What do I mean by that? Alana is constructing a plausible narrative for what this woman's motives might be. I feel like some of our confusion is that your patient is non-mentalizing. That's my suspicion right now, that your patient is not able to present us with a plausible rationale for what her motivations are. So this is what, there's a difference between mentalization and empathy. Empathy is deeper than mentalization. Is that right now we could go around the room. Alana gave a very good example, like why might she do that? One example would be, well, she has major mental illness and she's out of control. We're not mentalizing when we do that. More deeply, but still, she doesn't do that every day. Why does she do it? So Alana's saying, well, is he leaving like when, they just finished eating dinner and it's time to give all the kids baths, and he says, I'm going to go out now and buy batteries, and he's going to be gone for like 3 hours and leave her with like bath time and bedtime, and so she's mentalizing, like she makes more sense than he does. He doesn't make sense. Like he's just telling us like, well, my wife's insane, so what should I do? What do you mean? But like he doesn't really give us a good. So I wonder if he is a non-mentalizing patient, and that changes the diagnosis, the therapy, and the prognosis. People that cannot mentalize.
He is very hands-on, and the most recent case is like he was actually taking the children out of the house to take them to school, drop them off, and things like that. And she was conversation with him.
No, but you're getting into something that I'm saying something different. Like he says, well, I can't talk to her. She's emotional. She goes crazy. I can't have a conversation about it. But like most of us would not talk about our spouses that way. We would say, when I do da-da-da-da-da, she gets so triggered because of this issue and she becomes very upset, so I have to wait and I can talk to her the next day. He doesn't really tell, like you don't, it's like she's like a black box. And when you have a healthier, more tuned person, they give a more three-dimensional picture of the spouse. So I feel like that to me is suspicious, that he's not able to describe her well, and you have no idea. Like patients that are healthier, after a few months, if you were at a party, you'd be able to pick out the father, the brother, the husband. Like you've heard enough about them, you know what they're like. You could tell their personality from what they're talking about. Just even though you never met them before, you would be able to identify them like on an audio tape. We don't know her. Like he doesn't. You don't know her. I think he's bad at. I don't think he understands her fundamentally.
That could very well be, but from what he does describe, and has a lot, it's a very it's hard to describe it, but she's talking like when she's having a conversation with him, it's going on and on and on and on, which it could be normal like for people to talk, and when he's one of those,
Right? He's
it's 3 hours later, literally.
So he's describing. He's not. In other words, he's describing what happens, but he doesn't put it together as like a narrative for what her motives are, why she feels the way. Has anyone never heard of the term mentalization? Raise your hand if you haven't heard of that as a technical term. You haven't heard of that. So mentalization is, so Target and Fonagy, they're British psychologists and psychoanalysts. It's their concept. Mentalization is the ability to imagine a plausible reason for someone's motivations. And people who do not mentalize often have borderline psychopathology. People with borderline personality can't mentalize. People with low IQs can't mentalize, and it's a major challenge for interpersonal relationships because people are sort of like people that are very, very narcissistic sometimes can't mentalize because they're just so absorbed in their own worlds in that way. It's not, empathy is my accurate ability to participate in your inner emotional experience. That's empathy. It's an actual experience of your feelings. That's what empathy is. Like it's real. It's a capacity. Mentalization is more basic. It's just the idea that when I think about you, I might be off. It might be unempathic, but I'm trying to imagine why you might do what you're doing. If you come in and yell at me, if I mentalize, I think, oh my gosh, I must have really offended you. What did I do wrong? Or you're having a bad day. If I don't mentalize, I'll just say, well, he's stupid. He's crazy. I don't even think about it. There's no attempt or effort to understand what the person's doing. So it's a major problem. There are tests for mentalization that you can do. You can assess it. So so when you have you've all had this experience before. When you have a non-mentalizing patient, their narrative is very confusing. It doesn't make any sense. And you don't feel connected with them. You don't feel like you understand what their motivations are. They don't explain other people in a very good way, And so that's what this guy, I think, is. I'm suspicious. I think over time, if you continue to have trouble understanding, what the hell's happening in this person's life,
I'm going to try to get her perspective of things. I think that was a few weeks ago. His statement, so we're going to talk about having her narrative.
The director of the psych program I think it's at Einstein, is a mentalization researcher, and we brought him to speak at Nefesh, and he was speaking on mentalization. And I was sitting next to Alana, and she said, "When is he going to start bending spoons?" That's what she said to me. that was when we met. Where was it? Was that in Staten Island, or was that in Great Neck? I forget where that was, but it was in Brooklyn, right? It's in Brooklyn, right? What time is it? It is 9:53. I think we don't have time for one more case. It's unlikely. But any other thoughts about this last one or any of the stuff we've discussed so far? Yes. Now, I just want to explain something. People with avoidant personality all do mentalize. That's actually the whole personality disorder is based on imagining other people scrutinizing and judging you. It's a very, that's actually why people who are avoidant personality are actually really easy to work with in therapy. They're very easy to work with in therapy. There's a whole very alive, imagined mental life of other people, and they're very highly attuned, and now it's distorted often or always, but they are very attuned to what other people are thinking about them. It's inaccurate, but they're very into it. They're thinking about it all the time. Yeah. Yeah, well, right, so more information from her. Something is very fishy, though, about the history. Sure. I super sensitive. So right. So I'm familiar with the literature in adults. I don't know when mentalization. I don't know the age developmental stages for mentalization with kids. I know by adolescence it's intact. If people talk about others in a way that there seems to be like no effort to understand why they're acting that way. That's someone who doesn't mentalize. So
Not in terms of them internalizing it like it's a personal affront.
I think if people take it personally, like they're insulting me or they don't like me or they're rejecting me, I think that is someone who's mentalizing, actually. It would be more like I'm very upset that such and such happened, but there's no sense as to like, well, you provoked that person or that, like, why is the other person doing that? There's no if there's no curiosity about why someone is doing something, no effort to understand it, I mean, you just don't think that all of us in this room, when something happens, we construct a narrative and the other people's behavior makes rational sense in some way. Well, people with narcissistic personality, it's an issue that their need to protect their self-esteem and sense of self is like so frantic and desperate that they're engaging in this really desperate attempts to keep their self-esteem intact. So they might also have trouble mentalizing because they're only seeing other people as objects to serve them, but they're going to be talking all the time about how wonderful they are or how insulted they feel, and so like the effort is going to be on the self-esteem. So the therapy is going to be very much about their self-esteem regulation, and people with narcissistic personality do gain the capacity to mentalize when when they mature and their ability to regulate their self-esteem improves. It's not really a mentalization problem. People with borderline personality are so unstable that like they're not attuned to other people's motives. They're not. I mean, like if you think about like sending a message to someone and you don't get a text back. So what do? We're like, oh, she must be busy, must have her phone down. People with borderline personality, like that could trigger a whole crisis. There's no ability to imagine what that other person might be doing because they're so absorbed in like the fear of abandonment and being alone, they can't really think about what the other person's needs are, what the other person's wishes are, motives are. So that's how you see it play out in some of the personality disorders. But it's helpful if you just see someone like not able to do it, thinking like, yeah, like this is really like, I don't understand anyone. Like this person, there are people that like, it's just the narrative doesn't make any sense. Sometimes the therapy won't go anywhere. If you're not attuned to the fact that they can't mentalize, you just end up like not clicking with them, and it feels like it's not a fit because they don't operate in the same way. That's why it's a helpful concept, is when you recognize someone has a problem with it, it's like, oh, that's actually what's going on. Like it sort of makes the clinical scenario seem less confusing. That's probably your first intuition. Your first reaction is going to be, I'm confused about this person. I don't understand the story. Who are the people in this person's life? What do they do? What are their, your patients that you like working with and have good therapy, you know what their brother's sense of humor is, and you know what their kids are like, and you know who's anxious and who's not anxious, and who likes them, and who. I mean, you learn the whole constellation of the family. People that don't mentalize, like they don't describe it, like it's not really on their radar. So you just are like, what the heck's going on? Like you just feel confused by it. So Fonagy and Target. Target is spelled like Target, Target. They're the ones that write about it. Target is like, I shop at Target, not Target. Target is like Target, yeah. Fonagy, Fonagy. It's their concept. It's but that's what I think is maybe happening with him. Well, thank you all. Nice to see everybody, and so look forward to interacting with you at the conference and also hanging out later tonight. So I'm going to ask, this is not recorded. I feel like there was too much identifying information. Yeah, well, it is recorded. I'm going to ask them to delete it, not released, right? Other than for your patient's husband, other than for him. Yeah.